Sure.
Thank you all for coming to hear what Dr. Ramani has been doing at UC Irvine. And you heard us talking a little bit about his background. He's the founder of the Health SciTech Group at the University of California, Irvine, and the co-founder and associate director of the Institute for Future Health, a campus-wide organized research unit at UCI. And you heard me perhaps ask him about his background because while we are a multidisciplinary group between technology, medicine, neuropsychology, he's kind of a one-person multidisciplinary researcher. He's an associate professor of nursing, computer science, and electrical engineering computer science at UC Irvine, and a lifetime adjunct professor in embedded parallel distributed computing at the Department of Computing of the University of Turku in Finland. So he was just telling me that his original background was in hardware design, and then he moved to software, and then started to focus particularly on digital health and future of health. So thank you for coming today to talk to us about your future health program. And I'll turn it over to you, Amir, to start talking.
Sure. Thank you so much for the nice presentation. Let me share my screen. All right. Just a moment. So can you see it full screen now? All right, perfect. All right, thank you so much once again, Professor Cook, for the nice introduction. I'll just quickly go through the presentation. And in this presentation, I want to talk about some of the research that we do in our Institute for Future Health. Of course, all these projects that I want to discuss today are collaboration with domain experts, with clinicians, with nurses, with psychologists, and so on. And I'll try to, of course, acknowledge their contribution. But before I really talk about those specific projects, I wanted to just reiterate and mention a little bit about our institute, this IFH, and our mission at this institute, because you're gonna see some of these missions kind of being reflected in these projects, because I want to revisit and maybe have a pointer to this idea of health navigation when I go through some of these projects. So what we really do at IFH, which is a campus-wide organized research unit, or you here at UCI, we try to work with UCI Medical Center, or with our Vice Chancellor of IT and Data, to see if we can build a platform to bring different researchers on our campus, of course, working on different fields and dealing with different type of data under one umbrella. So we started this center, we started building infrastructure, for example, to bring holistic data of a person under, if you will, one roof. For example, if you have data regarding like everyday settings on sensors, or if you have EHR or omics or everything, how you can bring both clinical and everyday setting data in one platform, or start using that towards more precision and personalized health. And of course, we also partner up with some external partners and industrial partners to host the data, because privacy and all these challenges are very critical. So that was the first mission of that is still the first mission of our center. But we noticed that even if you have all the data in one place, interoperability and those things, even assuming they are solved, what would be the actual value? So if you really want to translate that to value, we really need to start fusing the data and go a little bit beyond just data integration and sensing to more sense making and building perhaps personal models for example, participants, because at the end of the day, we're really interested in personalization, and we know each person is unique. And by personal models, a metaphoric, or kind of as I said, a metaphoric example might be the same way, YouTube, Netflix, or all these companies build a personal model of a client with each interaction that you have, you purchase a new product, or you search for a new term, keyword, and all these things, and they keep updating and tracking the personal model so that they can provide personalized recommendations for you when needed. So this was one angle that we needed to add to this model. And also the next part was this notion of cybernetics, how we can go beyond episodic open loop care to have this more perpetual monitoring and guidance, because at the end of the day, we need sometimes like lifelong navigation, right? To be able to reach our goals. And this is not just a one-time recommendation. We need a step-by-step recommendation. We need to have a goal and a way to monitor our current state to be able to see what should be the action to reach the next step. So these are two angles that we kind of added to this whole idea. So that's our mission. And we have been building like applications and solutions to really realize this idea of health navigation and health promotion to personal health navigation. And we're also standardizing this PHN together with ISO standardization organization, because they're also interested in this notion. We formed a new working group under ISO, it's working group 11, that is focusing on this, and we're closely working with those guys. And I'm going to also show you some platforms that are required if you really want to have this kind of notion realized, because at the end of the day, interoperability is also very, very critical. All right, but this is at a very high level what we are planning to do. To realize this notion of closed loop health navigation, we noticed that definitely from the IT or computer science and informatics side, you need to have certain enablers. So certain tools for data integration, data capturing, mining, and so on. So I'm going to quickly go through some of these tools, because later in the talk, you'll see many of them being deployed. So this way I don't need to repeat these tools when I talk about them. So we start developing some open source software, some of them together with industrial partners. So the first tool that we started building is called Personal Chronicle. Remember, we want to go from not only have access to clinical setting data, we want to also go to everyday setting. And we know measurements in everyday settings, if we do not put them into context, they may not be really informative. They will be noisy. We really need to know the context to understand if that, let's say, an anomaly is really an anomaly, or it's just because of the context you see certain patterns and so on. So really need being able to understand the life events of a person is critical. So we started about 5 years ago to build this Personical platform, Personical 1.0, if you will, which does automatic life logging. It fuses every sensory data that it can get from your smartphone, from your wearables, any source. It's multimodal. It's a multimodal solution. Let's say in this scenario, it looks at the ambient noise, your calendar, your accelerometer, anything else that it can get, and it tries to log your daily activity into more like high-level log. It's definitely beyond just things like walking, running, cycling. These are easy. We want to really go to more sophisticated levels of daily activity, as per Daniel Kahneman's categorization. Really understanding, let's say, if you're in a meeting or not, if you're working, commuting, what's your feeling at that time? It's like a stress level. So kind of stacking all the information and try to go beyond just simple daily activity to more like personal chronicle of participants, because then we're going to need that data for many other, let's say, behavioral studies, for tracking if a person is adhering with certain, let's say, recommendations or not, or even if the the recommendations or any interventions effective or not, because if it resulted in any kind of life or behavior change or improvement in the wellness. So that was about 6-7 years ago. This app is already available in Google Play. If you search for Personical app, you can download it and start installing it on your phone, and it logs some of your activities. But about 2 years ago, we noticed that this platform needs to be more comprehensive. So that was the time we kind of made this partnership a bit stronger. We put about 3 FTEs full-time working on building actually a data platform which can ingest data from any sources, from wearables, from EHR, from external, let's say, data about social determinants of health, from environmental APIs regarding your food, or even EMA and everything, under one place, and providing REST APIs to access the data and to do also more advanced things like event mining, data mining, and so on and so forth. But it's really around, at the end of the day, this notion of events. It's really event-driven. So I encourage you to look at the personical.org. You can already connect your, let's say, your Fitbit account, your Apple account to this platform. It allows you to access all your data in one place. As I said, either you can connect your old data or start even continuously monitoring yourself. And it also provides certain, for now, basic event detection, also tools and dashboards for you to be able to track your life and any changes. But that was one platform very critical to our mission. The other platform, which is more like a also data provider or data sensing platform, we call it Zotcare. And this platform is, when we started this center, we noticed that we really need a flexible remote monitoring platform that can support, let's say, researchers or anyone who wants to, perform studies on remote patient monitoring with flexible dashboards and APIs, let's say, to plan a study, like, to form a cohort. Let's say I have a control arm, I have this intervention arm, and then be able to connect, let's say, wearables to this platform to have a custom application through which you can communicate with the user. For example, you can send personalized notifications, or you can collect EMAs, or any kind of interaction. But in addition to the phone app, also having ability to connect, bring new sensors. Let's say it can be wearable sensors, it can be portable sensors like smart scale or smart Bluetooth, and all the blood pressure monitor, everything else. And also it supports dashboards for clinicians, for researchers to track the data, to visualize the data, to let's say if you want to send random EMAs, to schedule those kind of things. So it's really a flexible platform to conduct studies. And we also started building this. Recently we went to the Zotcare 2.0, which is now very more robust and running on cloud, and about maybe 20 studies on campus here at UCI, and some also outside UCI collaborators are using this platform for their studies. And I would be definitely happy to talk to anyone on this Zoom talk if they're interested in knowing more about it for their studies. Food and diet is also very critical in our life. For example, I can reflect back on this idea of health navigation. There is this company called DiaNavi, or Diabetic Navigation, that is exactly using the same model. They ask participants or the users to wear a continuous blood glucose monitor, and then they provide personalized recommendations for these users with respect to their diet, their exercise, to reach them, for example, to help them reach their goals in terms of, let's say, A1C or their desired glucose level or something like that. But this multimodal food logger that we built is a bit more than definitely something like MyFitnessPal. It allows you to say take a picture of your food, or scan the barcode, or even use kind of voice to mention about, to log your food. You can rate your food. You can even connect your wearables. Let's say if you want to monitor the effect of certain food or drinks or whatever on your, let's say, sleep or heart rate or something, you can also do that. But in addition to that, it also captures a lot of context or contextual information around food. Let's say if you're eating that alone or with family, or if you're doing it in a restaurant or at home. Even if you're in a restaurant, it automatically using location APIs can, tap into the menu and also provide some healthiness score. Let's say this food is, looking at, for example, anti-inflammatory like index and so on, give also some healthiness score and so on. So it's really beyond just the food logging, and tries to help you build also, information or personal modeling around food, if you will. And at the end of the day, we're talking about a lot of data and lifestyle and EHR and everything, and how we can transform all these streams of time series data to events, to be able to do event mining, let's say looking at co-occurrence of certain events, or trying to understand the causal relationship between these different patterns. At the same time, that's also another line of research that we are doing. We have built an open source tool called Event Miner, which allows you to define your own events, transform your data to events, and even write queries and hypotheses to test certain hypotheses on that data or set of parallel events that you have identified. We have recorded videos on all of these short videos on YouTube. I'll share the slide deck. If you're interested in knowing more about this, you can definitely watch it later. But now let's get to the action part. I'm going to give you some examples of some of the projects that we've been doing. The first one is called Mental Health Navigator, but it's not on elderly. The first version we just tested it on college students, but the second and third ones are a project related to geriatric population. So in this personal mental health navigation, we were interested in seeing if we can, first of all, objectively monitor affect, emotion, and things around that, let's say stress, anxiety, and so on. And then if we can provide that information to caregivers, as well as to, let's say, an AI engine, to be able to provide, let's say, personalized recommendations and so on. And of course, along this way, if you're really interested in navigation, we always need to reflect back on the goal and the desired mental state of this subject, as well as building their personal models. That's what I mentioned also at the very beginning, that we really want to make sure every interaction is kind of captured, and we keep updating the personal models. So what we did as part of this study, in 2020, we ran a 12-month study starting from January till the end of the year. And that year happened to be also a very eventful year, because in March, the COVID started, and the election was in the same year. This issue with, unfortunately, with George Floyd was in the same year. So many stressors on that year happened, which is unfortunate, but research-wise, that was something desirable, because we could study some of these, the impact of some of these events also on our, on our cohort. So what we did in this study, we gave about 20 students 2 wearables. So we gave them a smart ring, an Aura smart ring, which can capture, if you don't know, it can capture your sleep, can capture your physical activity, your skin temperature, your heart rate, even some high-level heart rate variability index is provided by this. But because it only gives us process data, we also gave our participants a smart watch, an Samsung Active 2, because the good thing about this watch is that, like a smartphone, we could write our own app and run it on it, a smart watch app. So that allowed us to tap into the rod sensors of the watch, let's say, really collect raw PPG or this optical sensor, if you will. I'll show you the waveforms if you want. We can tap into the, for example, raw accelerometer, raw PPG to download that and send it to our own server. So kind of bypass also Samsung's ecosystem and have access to raw signals. But in addition to that, we installed this Personical app, the Personical 1.0 life logging app, to also capture the lifestyle of these or life events of these participants. And another smartphone app to this was a background app, right? Just running in the background of the phone and automatically just capturing things. But we also had a foreground app to collect EMAs, self-reports, also weekly and sometimes even monthly questions. So one of the things we wanted to do in this scenario was to see even if it's feasible to capture someone's stress, in everyday settings, because that's a challenging task given all the motion artifacts or confounders and everything that happens in everyday settings. So just a little bit background. I know I'm acquiring to the bridge, but I'm preaching to the choir, sorry. But the idea here is, can we monitor by having access to raw signals in this scenario, PPG, or you may call it pulse ox, I don't know, there are different terms for that, but it's optical sensor that monitors the blood volume. Can we monitor the activity of our autonomic nervous system through, let's say, analyzing heart rate variability, and also, for example, resting heart rate and other features? Because our body is either usually in fight or flight mode or in rest or digest, and we know that when it's in fight or flight mode, our HRV usually drops, because then we have less elasticity and flexibility in our heart rhythm. So what we did, we got this raw signals from the watch. We transformed the data to different features, some of them time domain features, some of them frequency domain features. And also we did more signal processing to see if we can also extract other information, let's say like respiration rate, because if you zoom out, same signal, you'll see this low frequency component, and that's kind of your respiration rate. And that was also another kind of feature or source of information we used. And if you even have access to more advanced watches, you can even do like EDA/GSR analysis to also understand, the skin conductance and sweating for someone. But the issue is that when you do something like this in the lab, things are okay. You can get a good accuracy. In lab settings, we could even get up to 90+%, accuracy. But unfortunately, this is not the case when you enter, real everyday settings. Your accuracy can easily drop to 60 or even 50 something, which is almost close to, flipping a coin or useless. So that's why you cannot, unfortunately, use these simply this in everyday settings. You need to bring that contextual information, do more advanced adaptive filtering and so on, and also model building to understand and improve the accuracy. And also personalization is another angle, if you will. So what we did, we tried to build this active learning platform or system in which it's a little bit complicated. I'm gonna a little bit simplify it for you. So the idea is, we want to, let's say we have a model, for instance, built in the lab. Now we want to further improve that in everyday settings by smartly and intelligently sending new queries and EMAs to the user, so that, let's say, if we see any corner cases or something that our model is not really confident about, some distribution of this, for example, this features or signals are something that we haven't seen before, then intelligently collecting more labels and knowing more about that situation using this ground truth label that we collect from the user, to periodically update that model in the field. So what we did, actually, we built this platform, this three-tier architecture. Data is collected from wearables. It goes, and also we do a lot of live logging. Of course, we monitor context, location, everything else that we can get. And then we send it to the cloud. And in the cloud, we do a lot of signal processing, quality assessment. We don't want to do garbage in, garbage out, because PPG can really be sometimes useless if you don't capture or if you do not do quality assessment before you use that in your models. But when we do all of those things, then we look at the signal and decide whether we want to trigger a new EMA to the user to kind of collect new label for our machine learning, or if you want to just skip this one because, let's say, we have seen a similar type of situation before and it's not that much informative. That's in contrast with the situation that usually people, like other research that we have seen, they usually try to just send random EMAs, let's say 4 times a day, 5 times a day. And we know that because there is a human involved, we cannot send like 50 times a day because no one's going to answer. Even if you're lucky, there you get 4 or 5 times a day EMAs. So to really use or utilize or maximize the utilization of our quota, let's say 5 EMAs, we wanted to make sure we really kind of send 5 very informative kind of queries for EMAs rather than just maybe sending something and maybe the person is even not in a situation to answer the question, let's say sleeping or in a meeting or something like that. So this notion of context helped us not only build more informative solutions, but also and faster converge to a higher accuracy, but also make it more, from the HCI perspective, more user-friendly, because now we could understand what time works best for this specific user and just trigger and send you EMAs based on their availability. So that's a very high-level description of this platform. And I'm not going to go through the details, but for that, we use this notion of reinforcement learning and deep Q networks. And this deep Q network, as I said, it has some objectives, some rewards, and it looks at which time of the day in the past work best, what's the uncertainty of the model, the response rate at that certain time, and tries to optimize the action, which is like sending or not sending a query based on this function. But I'm going to just show you a quick, some quick results. For instance, here, random EMAs compared to random EMAs compared to this active learning solution. You see, the active learning solution really needs a lower number of queries, like maybe 6-7 times lower number of queries to reach to a certain level of accuracy. So you can converge way faster. And also, if you're interested in seeing like how quickly your kind of the accuracy of the model can increase, again, we have here 3 different policies: the random selection, this active learning deep Q network, and also another variation of it, which is contextual active learning. And you see both of them are much better than just sending random EMAs to the user. But that's the very high-level idea. You can borrow the same idea and this active learning and try to use it for a different objective, not necessarily just for EMAs to for your machine learning model, but just, for example, to understand what time works best for a person, or which context has the best chance for you to collect, new labels and EMAs. But going back to the study that we ran, this, as I said, this was a study in 2020. We collected ANS activity, sleep, physical activity, life logs, and also some self-reports, let's say depression index, loneliness, some positive and negative affects, and so on. And for the sake of, just showing for an example, let me just show you one scenario. This is a real scenario, one participant, just a scenario that you can see clearly the association between subjective and objective measures. This is one of our participants. I call it participant X. At the beginning of this study, around, before, around, I guess, around maybe January or February, but definitely before COVID lockdown, he or she was doing well. The BDI score was, this depression score was 8, and if you know, the cutoff for mild depression is 14. This person was doing fine. He or she was relatively happy, well adjusted, and doing well in quizzes and everything. But then we noticed in April, after the COVID lockdown, that the score increased to like 24, which is a huge kind of, rise compared to where it was. So of course, my partner, Professor Jessica Borelli, who's a psychologist, reached out to this person, and we understood that this person is experiencing significant COVID stressors, academic stressors, and moving, back to live with their family, and a lot of other things. So then we decided to look at the data, for example, of this person before and after, or before COVID and during lockdown, to see if we see any changes in, for example, their sleep, their HRV, and so on. And surprisingly, we actually did see that. For instance, here, this is an objective measure from the Oura ring, and we noticed that the sleep quality of this person dropped by 3 units. We noticed that the resting heart rate increased, which is a negative thing, right? And also the RMSST, which is a time domain value of HRV, heart rate variability, decreased. This is also a negative sign, because we want our HRV to be higher. The higher, the better. The daytime HRV was also dropped. But then when we compared it to positive and negative affect, you see the positive affect dropped significantly and the negative affect increased a lot, And these two are subjective and everything else is objective. And you see they really kind of match. And you see not only, the perception was, they're feeling more negative, but also their body almost felt the same. If you really go through the timeline, look at some of the days, you'll see that, for instance, during that time when this person was doing okay, the maximum resting heart rate was in this scenario, for example, was 90 or 92, whereas in this situation, it's up to even 100 something. And the same thing here, you see, this is the positive affect, very steadily like high, and a negative affect low, but here it's all over the place. It goes up, it goes down. So, and the same thing applies to their sleep quality. If you look at the results, you'll see that all of them align. But this was more or less the feasibility of, seeing if we can objectively monitor mental health, and how we can develop tools to monitor continuously autonomic nervous system, HRV, and so on. At this stage, we are running an intervention, a closed loop intervention, which is like a relational savoring for our population. Hopefully next time I'll also show you the closed loop information on how this navigation part is helping them. But that's a study which just finished recently. Because the first one was observational, but we recently finished an interventional study too. But let me now switch gear and talk about another project, which is an NIAR1 that I have with one of my colleagues, Dr. Jingao Li. And this is on helping dementia family caregivers, or supporting, especially from a diverse population, mostly immigrant dementia family caregivers. And in this project, we also use wearable technology to objectively monitor our participants. So the idea is, as all of you know about it, family caregivers, especially family caregivers of persons with dementia, they really suffer from stress and negative, emotions and outcomes, especially because of this round-the-clock caregiving responsibilities. And their, challenges and experiences are twice and they are twice as likely to experience these emotional and physical challenges compared to caregivers of persons without dementia. So there, this is a much higher prevalence, and sometimes they're even called the invisible second patient. And to this, you can also add this fact that if you are also from diverse family, let's say in our studies, we have Vietnamese, Korean, Latino, they also have this lack of awareness of available, community resources, and also a little bit limited, for example, support around them. So we were thinking maybe through this model of having community health workers and training community health workers, or CHWs, we can help educate these families through home visitation programs, through some interventions on managing their stress and reducing their caregiving burden and so on, and kind of supporting the family caregivers in this scenario through this model of community-centered care, if you will. So the purpose of this study is actually to, as I said, to alleviate the caregiving burden and stress among diverse dementia family caregivers. And the idea is to provide them with caregiving education, stress reduction and management techniques, and compassionate supporting and listening. And through these home visitations that happens regularly by community health workers who are from the same, who have to have the same background. They are from the same community, they speak the same language, and they know this is also culturally sensitive. So we divided, of course, to really study this properly, we divided our cohort into two groups, an intervention group and a control group. We first, in a pilot study, ran this 1 month study, but then we also, for the actual R1, we went and implemented this for a longer period of time. We trained a lot of community health workers. All of them are bilingual, depending on which population they serve. They speak Spanish, Vietnamese, Korean. And also to objectively monitor the effect of this intervention, we gave our participants, wearable devices. For example, in the first study, we gave them a smartwatch, and the second one, as part of R1, they also receive a smart ring. And in addition to the subjective self-reported measures, we also monitor their wellness, their sleep, their HRV, and so on. Just giving you some high-level results on the impact of this study. I have backup slides on demographics and more details if you're interested. We can leave it to the Q&A, but just some highlights. These are some of the subjective results about depression, burden, self-efficacy, and this behavior score, PW behavior score. And we observed a significant improvement, effect size in almost all of these outcomes, even during 1 month. This is our pilot data on about 30 participants, if I'm not mistaken. And different population, of course, we had Latino, we had Vietnamese, but almost all of them had significant positive, depending on their self-efficacy increased, and also everything else was significant as well. But this is a subjective one, but we wanted to also see if we can find anything interesting from the wearables. So we looked at their HRV or RMSSD. Here we call it stress, but to be more accurate, this is their HRV, or time domain HRV value. And we compared that during this 1 month of home visitation and intervention, there was about 13% improvement in terms of stress, or HRV, if you will, and the p-value, of course, is significant. But we also start looking at their sleep to see if we observe any positive sleep changes. Most of the sleep is quite multifaceted. You can look at the duration of the sleep, duration of REM, deep sleep onset latency, how many times a person wakes up, all these different things. In one of these factors, we found an interesting result, which is like about how many, the awake duration. But after they go to bed, let's say in the middle of the night, they wake up, how much is the duration of this awake period is in total. And we noticed that in our study, we had this 44% decrease, if you will, in this awake duration in terms of minutes. So we went, 44% less than when it was at the beginning. We're talking about a lot of data. We have, for each participant, we have at least 80 to 90 days of data, 90% of their data. And it's a really repeated measure, intensive longitudinal study. So the p-value, that's why, is also significant. But something else that might be interesting to you is the feasibility of this, right? How many days did our participants really wear a device? This is the first pilot study. And as I said, we had about close to 30, if I'm not mistaken, participants. And we noticed that on average, the average daily use of the smartwatch for the family caregivers was about 18.3 hours, which is a very good number, given that they need to charge their watch, and that definitely, you can never get 24 hours because they need to charge it and many other issues that they may have. But if you look at different, let's say, different background, for example, Latino group, Vietnamese, for example, Latino had and Vietnamese had very kind of high wear time, whereas our Korean population had a bit lower, but overall very kind of decent. And in our current study, because our R1, we are targeting 400 participants. So far, we have recruited close to 200. We have, this has been a very heavy, because this is not an easy study to run, because a lot of recruitment needs to be done, but we have been so far lucky because we work with community organizations in Southern California. But so far, and these guys, this population are wearing a smart ring, and not only the family caregiver, but also the clients are wearing this time the devices. So we had about so far on average 18.5 hours for the family caregivers and 20 hours for the clients. It's even more than family caregivers to average wear time, which kind of shows this is a feasible way. And by wear time, we mean we measure wear time by looking at our servers to see at what time of day we really have data. If we do not have data, we assume it is off or they're not wearing it. So this means that our missing data is not that much. So I have one more project that I can go through, but I want to, because my presentation is kind of elastic, I can keep presenting new projects. But before I continue, I want to see if I have time. If not, maybe I can stop here and take questions.
I have an overall question, but I can wait till the end. So I don't see any raised hands, so I think you can go on and we'll ask the questions at the end. Okay,
and I'll try to wrap up this. This is the last one, hopefully in 10 minutes, so that we have time to also have enough time for Q&A. This is another project that we started about 2 years ago. It's funded by NSF Future of Work program. With some of my colleagues, for example, Dr. Gibbs is a geriatrician, and working closely with this senior health center at UCI Medical Center. And the idea is, I just presented this notion of community health worker who assists, or trained to for health promotion in the communities. So we had similar studies in the past where, for example, we worked with organizations like Moms Orange County that help underserved pregnant mothers and similar organizations. And we observed that many of them have this community-centered care model in which they have a limited number of RNs. For instance, this mom's OC, they had only 4 RNs, residents in their buildings, but each RN was is supervising, let's say, about 20 to 30 community health workers. And these community health workers provide home visitations and educations, and they go and visit this underserved population in Orange County, and they provide, as I said, a set of interventions and so on. So to make this model more effective, we thought maybe we can bring this notion of, we call it community-centered care. We thought maybe we can make this platform more scalable, more effective, especially focusing on preventive health, and bring this notion of digital health enabled CCC, or going from CCC to DCCC, to kind of address some of these manual and restricted and unstructured workflow that they have to a more like scalable and digital and automated space. But we, of course, ran a lot of qualitative studies, focus groups. We built a CAB, a community advisory board. We had a lot of interviews to do needs assessment with different stakeholders, and we noticed that they're not only interested in remotely monitoring, for example, even blood pressure of these participants or some vital signs, but also to make it more useful. They're interested in also not only what is happening, but also why something is happening. In fact, more like contextualization of the readings. They want to know, because they want to provide useful and personalized recommendations. They need to know whether, for example, if someone's hypertension is not well managed, if it is because of their diet, or maybe some mental health issues, or maybe the lack of exercise. So they needed more information on just the readings. Especially in this population, they have a lot of cases that mental and physical health comorbidities are there. And so the idea was, we wanted to not only do sensing, and we don't want to not only do sensing, but also go beyond that and try to do sense making, and try to connect these community organizations through our technology to the families, not only the client, but also the family caregiver. All right, so that's why we started actually building infrastructure, extending our infrastructure, and using some of the tools at the beginning of the presentation I showed you. We have, for example, Zotcare and Personical, which does a lot of data collection, but then transforming that to events of different types, physiological events, like psychophysiological events, daily activities, and context and everything, and then fusing that data to be able to test certain queries, or produce some actionable insights, or show certain patterns, or do comorbidity analysis and risk factor analysis for our users. I'm sorry. So, and of course, we needed to also have some user interface and dashboard and so on. I already mentioned about this as part of, first we had this planning grant, and we did a lot of qualitative research, both English and Spanish, with our partners, with insurance companies, with industrial also companies, and as well as with this National Association of CHWs and some other institutes that do training of CHWs. And but we wanted to also run a small pilot study to see if in this population we can track or even monitor, let alone the sense-making side. First, we wanted to see if in this population we can implement kind of a smart monitoring platform. So what we did in this pilot study, we gave every participant a smart ring, and also the caregiver a smart ring, because we wanted to monitor not only the well-being of the person, the client, but also the caregiver. But in addition to that, we integrated some new devices to our system. For instance, we worked with this Things company. We integrated their smart blood pressure cuffs that they, for example, sync and connect to their home Wi-Fi or to the phone Bluetooth. And every time they measure it, the data is automatically pushed to our servers. Sorry. Then also we give every family a smart scale, again from Things, which monitors their, of course, their body weight, but also their body composition, body fat, everything. And also a Tizen watch, the same watch. In addition to that, we built a custom mobile app for the family caregiver, not for the client, because our clients in this scenario are really old, and some of them, and we only had this app in English language and for the pilot. So the caregiver was supposed to not only fill out the information about some of his or her own well-being, but also if there were any adverse events for the client, let's say a fall happened at that day, or if there was a fatigue or something like that. So some daily questions also were pushed to their phone to answer. And then we designed dashboards for the RN sitting in the facilities of this Meals on Wheels. I forgot to mention, this was a collaboration with Meals on Wheels Orange County. And they have an RN there who supervises community health workers. And we customized this app. We added smart alert for the RN. We had a lot of meetings with her to really understand, because she didn't want to receive a lot of alerts every day, or she doesn't have time to go through all this data one by one. But instead, let's say every time for a specific person, there is like an overshoot of some measurement, she wanted to receive notification and stuff like that. So we ran a very small pilot study, just 10 participants in this study. And as I said, we built dashboards and tried to have this platform up and running to monitor different things like blood pressure, sleep, and anything that we can get out of these devices, honestly, and also report them daily, weekly, and so on. We just finished this study. Hopefully, again, soon we'll be able to share some more high-level outcomes, but I at least have some data around feasibility again that I can show you. The mean average of a population here was, for the clients, was 73. For the caregivers, a little bit less. All of them were Hispanic, low income, low kind of educational level, and some history of mental health problems, but not during this period, because we tested this PHQ-2. And as usual, we observed that this Oura-Ring is quite feasible. And many of our clients used it. In fact, in the next slide, I'm going to show you that even one of the clients were so enthusiastic about this. She wanted to be able to have the reports to show the doctor, because she was complaining about some of the sleep issues that her mom had, and but this data was just so informative to kind of have a proof of, this is happening to my mother, and I want to know more about it and why this is happening. But also the blood pressure monitor was well received. The average usage was quite also high. Most of the days they did measure their blood pressure, but we didn't get that much luck with the body scale, especially because the average of our clients had some disabilities, and some of them even had difficulties to stand up and stay on a scale. That made it a little bit hard. And these smart scales sometimes have this issue that you need to stay a bit longer on them, because they do calculate your body composition and a bunch of other things. So you need to stay, let's say, 5 to 10 seconds on them. So a little bit issues with the body scale. The N is small, but that's what we noticed, at least in this small study. But something that we noticed regarding our stakeholders input, then the caregivers liked it a lot, because it also gave them some ease of mind, knowing that their beloved family member is being monitored, and the staff are on top of any changes. The meal zombies nurse, of course, she was interested in all the remote monitoring parts, especially blood pressure and weight, but also she mentioned that this system helped her to capture some self-reports, for example, around falling, which usually goes unnoticed. But this, at least here, she captured some of them and even reached out to that client by phone to see if, if any referrals are needed and so on. But that's a very high level part of their exit interviews, and still we are analyzing the qualitative data, and hopefully we'll be able to publish something regarding this soon. Here's my last slide, just showing that we are taking some of these platforms to the next level. There is this large grant here at UCI and UCLA called SERV-OC. And here again, in this scenario, I'm a co-I in this grant, but the PIs are planning to use this again, community health workers to manage hypertension in underserved populations, and they're giving every family a multi-user small blood pressure monitor, where, for example, using which you can monitor yours and also your husband and your wife and anything, or your family, other family members. And we just finished designing a dashboard for this study. About 1,000 families are being monitored starting from next month. And, we managed to also extend our tools and tool chain to accommodate all the needs of a large study like this, just to showing you that our tools are a bit more than just tools built in academia, and they actually now serve large scale projects. This is just around hypertension and blood pressure, and also a simple mobile app to send some educational materials. But that's another study that is taking place quickly, and hopefully next time, if I get a chance, I can share some of these results with you. Yeah, so with that, I want to first acknowledge all the collaborators in all of these projects. I didn't get a chance to put many others. The list is even longer than this, and I would be happy to address any questions if there are any.
Yeah, thank you for this terrific talk. You're very active. I'm first going to ask questions on behalf of people who posted them. Asafa says, thank you for a very nice overview of your interesting projects. And he has questions on the second project when you use active learning, and wanted a little bit more detail, if you can provide it, on the method that you use for active learning.
Sure. Here? Yes. So on this infrastructure, or on the internal component of the active learning?
I think, Asafa can speak on his own behalf. Let me know if I'm wrong, but I think he's interested in the active learning component itself, not necessarily the infrastructure.
Yes, sure. Here that, I have also some results that I can share with you. It tries to, in active learning, here we use reinforcement learning, and the idea is to maximize a reward, right? And here the reward is, getting more EMAs answered, and also not only collecting more EMAs, but also see if those EMAs are really kind of helping increase the certainty of our models. So that's why in our objective function, we use, for example, a time of the day to notice like what time of the day increased the probability of getting a response, and also what context helped us increase the response rate. And also in this scenario, for example, how uncertain, when you do active learning, you have access to an existing model, and you can check, you have a data coming, you can pass it through your model, see if it gives you like a good or high good estimation with a high certainty. Let's say in a neural network can be like with a 90% confidence, it says this is 1 or 0 or something like that. If you're certain enough, maybe this is not a good distribution, that you want to collect more data instead, where you have more corner cases. Let's say sometimes you have a data for which you're not really certain. That's another kind of thing that you can include in your policy to maximize, try to maximize the confidence. So we did two different policies. One was like more offline, before really implementing this. I can share also the paper if you want. It's just under review for this Chase conference as we speak. But that's more or less the high level idea. In the first work that we did, we started having for this we had two variations. In one of them we really had a model, so we could look at the certainty of the predictions. In one of them we even didn't have any model, so instead we looked at the coverage of the feature in the feature space to see that if you're, let's say, assuming that it's a 2D plane, if all the data we're getting is only around one corner, and now we just see a data which sounds more like an abnormal situation, but it's really not, because it's just some new data and brings new insight. So we kind of try to label that. So you can do both ways. You can either just look at the input feature distribution without a model, or you can pass it through a model, look at the certainty, and depending on what algorithm you use, let's say if it's a SVM, you can look at the distance from the plane, or if it's a neural network. But there are different ways depending on what algorithm you want to use to implement this. But the bottom line is that those are just internal things. You can deploy anything here to maximize. Yeah.
Okay, thank you. I want to be sensitive to your time constraints and those of people attending. I have one question, but let me first see if there are other ones that we can ask quickly.
I have one quick question. Amir, oh my God, amazing. I don't even know what to say. That was such amazing work that you're doing. You came back a lot to context, which is so important in terms of interpreting the sensor data. I'm curious if there's like certain aspects of context you feel are like so important that we need to like really make sure we're paying attention to, or like have you seen anything like that in your data, I guess?
Sure, absolutely, and it depends on the study. It a little bit varies study by study. For instance, we just finished analyzing a study on monitoring loneliness and objectively monitoring loneliness, again in college students, but hopefully we can do it also in the future elderly. For instance, there we noticed context such as sleep is highly correlated with you feeling lonely next day. So sometimes you can use context directly to make conclusion and help you modeling and prediction. Sometimes you need to use context to understand and put measurements into context. For instance, physical activity is so important. During a physical activity, the PPG data that you collect, for example, either from ring or watch, is so unreliable. Sometimes it's almost garbage in, garbage out, and maybe the best you can get is just to get the heart rate. Even heart rate is unstable. So on a smartwatch, you may see things are okay, but they do a lot of post-processing, and when the signal is not accurate, they just show the previous number to you. They don't show, because we tap into the same raw signal from Samsung, and we compare it with what they report. It's, they do a lot of speculations.
Have you tried using like the active learning to get contextual information, like to ask for specific contextual information like at that time? And if so, like what type of contextual information are you asking for?
We did, for the sake of studying. In this study, we every time we send an EMA to ask whether there's stress or not, we also ask 5 or 6 multiple choice questions regarding what they are doing at that time.
Okay.
Just for the sake of study, we haven't incorporated that data in our modeling at all, which at least so far, hopefully we can. But we ask, for example, whether they're like sitting or laying down, or if they're kind of walking or doing any exercise, if they're eating, because what you eat affects your HR and HRV especially right after what you eat, right? When you do exercise, in a short term, exercise has a negative impact on your HRV, whereas in long term, after you wait for a couple of days, now you see the positive effect because it's a physical stress, right? Exercise is physical stress and affects your HRV in short term. So I would say things like certain diet, drinking, let's say coffee, alcohol, things like that, that's so important to capture. Physical activity is so important. And so far, if you want to do, that's my experience, if you want to do more long-term analysis, let's say understand the effect of your intervention, in 1 month or 3 months or 6 months, the best way, honestly, is just to look at nighttime data, nighttime HRV, nighttime HR, because then you have no confounders. You can have this consistent, you can control for many things, and just look at the resting, if you will, data. So, but if you're interested in short term, let's say if you want to have this just-in-time intervention, then that's a different story. You really need to understand at the moment what this person is doing.
Yeah, thank you. I know Diane has a question. Really excellent one.
Yeah, very nice. And I'll try to make this really short. I like your all-in-one interface and some of the comments you mentioned, like alert them if something overshoots. There's so much under the surface there.
Yeah.
I'm wondering if you have any overriding principles on how you settle on an interface design. Is it participatory design? How are you coming up with the interface that is most usable for these groups?
Yeah, that's a very good question, and definitely a hard task. That's why we recently, in fact, when we wrote our planning grant, we didn't have any HCI collaborator, but we noticed that we definitely need one, and that's when we included Professor Elena Agapi. She's a HCI person. So a lot of qualitative study and participatory design, as you mentioned. And still we're at the beginning because we just customize it for one organization and a handful of nurses there. You change the workflow, you change the organization, they're going to need something totally different. So that's an open challenge. Honestly, I don't have a good answer for that because these human aspects are very critical, important. And at the end of the day, if you do not address them, everything else will be underutilized.
Absolutely. I was hoping you would have a silver bullet answer, but it's a hard question.
Unfortunately, no, I do not have it.
Thank you again, Amir. Fantastic talk, and it helps our group to know what you're doing there. Thank you.
Sure, appreciate it. I would be happy.
Thank you.
Sure, to take questions if you want. As I said, many of these tools we do collaborate with external, anyone outside, many people outside UCI.
Right.
So if you need them, please feel free to reach out to me or to Diane. We would be happy to discuss.
Thank you.
Very good. Thank you, and enjoy the rest of your day.
Thank you. Likewise.
Bye.
Goodbye.